you guys hear me?
Yes.
Okay. Good morning, Dr. Nestera. Good morning, Dr. Mlawa. Good morning, Mr. Frank.
Good morning.
How is everybody this morning? I know it's 8 in the morning, but
midday this side.
good. That's good. Good morning, Elisa. Good morning, Green.
Good morning.
Good morning. Good morning, Dr. Christian.
For me, it's good evening.
Oh, yes, good evening. Yes. Oh, from where?
I'm in China.
Nice. Oh. Okay.
Yeah,
that's very good to know. And are you an OBGYN, NEO?
Yeah, resident. OBGYN resident.
Nice.
Resident.
Cool. What year are you?
I'm in second year. Just started.
Oh, second year. You lasted the whole year. That's a good thing. That's a good thing. We keep.
We're coming to visit.
You're welcome.
That's very good.
We'll wait for you to finish.
Okay, we just give you a few more minutes, 2 more minutes, and then we can start.
Rose Muenza.
Oh, that's the news from Russia. Let me see. This is her name? Not nothing.
My glasses on, that might help. So we have China, we have Dr. Mlawa, we have Gideon. We are covering the 4 points of the globe. And then we have Bree from Puerto Rico.
She comes in and hides. Okay, so 1 more minute, 7:06. Okay, I think we can start. So, good morning, everybody. My name is Dr. Harriet Gaboni Siakabe. I'm the president and founder for Qhsc. So we are going strong with year 4 for the organization. So this is one of the training that we do in preparation for the medical mission, which is in 5.5 days. Today is September 2nd, 2023. So thank you for everybody who came and joined us, especially for the US, because it's a holiday weekend, but we have to come and share this knowledge and be able to learn from each other. And then so next week when we go to Tanzania, then we can share what we have learned from here and take it from there. So to make our project more effective. So we do have our panelists today. It's almost everywhere in the globe, and I thank them, and I'm going to give them a chance to introduce themselves. We do have Dr. Mlawa from United Kingdom. We do have Dr. Emma from US. We have Dr. Nestori from Sweden, Dr. Mugalu from Tanzania, and I know we're going to take some input from Dr. Christine, who is in China, and all the attendees, if you have any questions, concern, or something like that, you can write the question on the chat. And then if it's at that time it's appropriate, then one of my co-hosts will help us to read those questions, and then the panelists can respond to it. So it's not like a presentation style. We want to have a discussion. So we want to try to learn what is the best practice from all over the world. And if we share those best practices, it's going to help us to learn and then impact our fellow colleagues to be able to learn and effectively save a life. So that's what the title of this training today is: Effective Triaging an Obstetric Patient, which will save a life. So we know if you miss anything from the triaging of that patient, we know complications and mortality could happen to that patient. So again, thank you very much, everybody, for coming, and we're going to start quickly. I am going to pull the screen of all the panelists, and then I'm going to let them start introducing one at a time. Hold on a second. Sorry. I know you guys probably are seeing my screen, which is, it's always likes to lock me. Do you see my screen right now?
Yes,
Which one do you see?
the panelists.
Okay, perfect. So you can see, they said the panelist was there. The meeting was supposed to start at 7:05. Now we're already on introduction part. In Tanzania, friends is 1400, and I am going to start letting one of the time panelists to start introducing himself. Dr. Mlawa, please.
Thank you very much. My name is Dr. Mlawa. I'm based in London. I think in today's discussion, I come as a physician, and I work closely with my team here with Obstetric Gyne team within Queen's Hospital in East London. And I think I'll bring into the panel as far as medical condition is concerned in a patient who is pregnant. And sometimes I get time to go and review them in the wards, but we also see the patients with maybe signs of danger when we see them in the antenatal clinic, which is joined the antenatal clinic, and we can send them either to labor ward or to triage to be seen and be assessed.
Thank you very much. Dr. Mlawa has been our ongoing support and panelist for Qhsc. So we always seek his expertise to come and support us in the training purposes. So you can see his vast experience, which we're going to learn quite a bit today. Dr. Nelson?
Hey, everyone. My name is Nestor Qhsc. I'm a resident in obstetric and gynecology in Sweden, in Gothenburg, Sweden. I'm doing, now I'm in my 5th year of residency, and I'm expecting to be an obstetrician and gynecologist by next year. So I would really like to share the experience from Gothenburg.
Thank you very much. We appreciate you. You have been coming back with all these obstetric emergencies, so we learn from what our colleagues from Sweden, and we appreciate that. So good luck. I know you can make it. You'll be an excellent OBGYN already, so we just need a little title. That's it.
Thank you.
Okay. Do we have Dr. Emma? No, not yet.
Yeah, she's here. She's here. If you want to just let her know that what you're doing.
Dr. Emma? She's situated.
Hey, good morning.
Good morning. So we do, I'll just give you the little intro from the panelists and give us little overview of what you're going to help us with this topic today. We had Dr. Mlawa from UK and Dr. Nestori from Sweden, all coming to contribute on the triaging of the unobstetric patients. Okay.
Oh, great. Hey, good morning, everybody. I'm glad to be here again. I am Emma Kulwa, and I am a practicing obstetrician and gynecologist here in Greensboro, North Carolina. And I have been practicing for now about, I think, over 15 years or so. And I work in this hospital with many patients. I do have a private office, so I'm happy to share what I know and what I do every day.
Thank you very much, Dr. Emma. And Dr. Emma has been recurring, or we keep putting her back. Yes, we keep putting her back to come and help us with her expertise in obstetric patients. So thank you very much. We're going to learn quite a bit from you today.
It's a pleasure. Thank you.
Thanks. Dr. Mugalu, is she here? Yes, from Tanzania.
Yes, hello.
Hey.
My name is Dr. Mugalu. I am a medical doctor at Mwananyamala Regional Referral Hospital. I practice in the Obstetric and Gynecology department. So I am here. I'm happy to be here with you and learn what others do so that we can improve our care.
Excellent. And I can't wait. We're coming to see you in 5 days. Yay.
Okay.
Yes, Dr. Mgaro has been also an ongoing support for Qhsc and training, especially for the obstetric area. So thank you again for coming and sharing your expertise. So definitely we're going to rely on you to come and fill in our gaps of what you guys do in Tanzania. And then that also will prepare us to come and do on our medical mission in 5 days and a half. So thank you very much. Dr. Christian, do you want to jump in quickly and introduce yourself, and then we can start? I can share the screen. Dr. Christian?
Hello, everyone. Can you hear me?
Yes, we can hear you. Go ahead.
Yes, my name is Christian. I'm from Tanzania, but now I'm studying in China for my residency. I'm in 2nd year. I just saw the link that was shared in our WhatsApp group back in Tanzania, Aga Khan Hospital, and I just decided to jump in and to what you guys are going to share. I have nothing really to share.
Yes, you do have everything to share because you're going to give us your expertise and experience. We want to learn what you are learning now. In fact, fresh eyes usually helps because sometimes people who have practiced for a while, they might take things, for granted in a way that, okay, they know that they can differentiate those diagnoses very quickly. We want those fresh eyes, fresh ideas, because you come in with a different level of, okay, why are you doing that? So you have all these international expertise in front of you, then quiz them. I would like to hear that. Ask them questions, so then they should be able to share their ideas from Sweden, US, and of course from Tanzania, definitely, to be able to learn. And then you can say, this is what we're doing in China. So definitely is the learning experience for everybody. And I appreciate you being here, definitely. Okay, I got all the presenters. Yes. I know I have a nurse. So I'm looking at my list here. Oh, she's not there. I thought
we lost somebody.
Yeah, Rose was here. One of the nurses from Arusha. Okay, maybe when she comes back, we can tell her to come and say hi. Okay, so let me share my screen and then we can start discussing. Wait a second. Okay, I got it. It always makes to look me out.
And we can see your PowerPoint.
Oh, you cannot?
No, we can.
Okay, good, thank you. Okay, I'm gonna pull this one here. Okay, so I said the topics today, we're gonna base our discussion, effective triaging an obstetric patient, which we all know that is gonna save a life. And for saving a life, I include mom and baby as couplets, so that's why I compare as life. But yes, we do have our panelists, we already met them, so they're great, including Dr. Christian, there you can run away. And then so objective is the 3 areas, almost like the 2 areas, and then the 3rd area is that's usually the outcome. We wanna make sure we improve the life of the obstetric patient. So one of the areas we're gonna be discussing the triaging process from different locations, different countries, and then in staging the PPH. So we're trying to see what things that the risk factor that the mom will bring, and we need to know as the providers to be able to identify, and then of course working with our colleagues in nursing and other disciplines to make sure we prepare or we anticipate what is going to happen to the mom, and then try to prevent it from happening. So especially for the postpartum hemorrhage, which is a huge number of losses we have there in Tanzania. And then the second one is discussion of the current screening. So what do we do to try and help this mom as she hits the floor coming to our hospitals or doctor's office or whatever the entry level to the healthcare? What do we do to try and help us? So we know part of it, Dr. Nestori from Sweden, he's going to share his experience, what he does with the screening part. And then I hope Dr. Mlao, Dr. Emma, and Dr. Christian and Dr. Mugaru will jump in and say what you guys order now or what you guys do now in anticipating that if the patient meet those risks, what are the things that you can screen now? So we can learn from each other. So let's say we find out your hospital does not do that. There's nothing negative about it. It's just like we need to know what other tools are available out there so we can all practice and use it within our means. And then at the end, we just want to find out to make it more effective, do we use quantification of blood loss as a guide to start doing the treatment, or do we estimate and hope that everybody has a good eyes of counting that blood loss for the moms and then plan for the treatment? Okay, so when we are discussing this, those objectives, just have it in mind that we have like two scenarios. So one of the patients will be gravida 5, T2, P1, A1, and L3 at 39 weeks gestational age. That patient is a diabetic, hypertensive, BMI of 32, no prenatal care, and then complaint of back pain. And she comes to your hospital or clinic like that. You do a vaginal exam, finding out she's on a 25% -3, and then she's intact. So that's the one you can, when we're explaining that process, try to base that information for that so we can see if that similar patient happened to UK, Sweden, China, Tanzania, or US. What tools do you have to try and make sure you anticipate what she might go through, or what things that you identify as risk factor for that patient? And then what did you do to try and make sure lessen complications for these moms? Or you can go to the one who is a premature G3 T0P2 A0 live 2 at 32 weeks. And then she has a history of preeclampsia. She's ruptured membrane for 12 hours, but it's clear. But the temperature on the admission is 101. And then she's complaining of the contraction every 2 minutes. So have that scenario. What are the things that you are going to put in place or identify, screen that mom to make sure whatever time comes to delivery and postpartum, she is safely taken care of. Okay, so with those scenario, I'm gonna start letting Dr. Mlao, since you work with a lot of screening parts, I'm gonna let you start the discussion. So let me leave my screen because I wanna see you when you're talking. Go ahead, Dr. Mlao. I can't hear you.
He's muted.
I'm a part of a big team which is joined antenatal and the obstetric team, and we tend to see different patients. Typical, an example of the first case of patient who is 39 weeks pregnant, but she's known hypertension and also diabetic. But in this case, if that kind of patient received a proper care from the beginning, he should have been under the joint antenatal diabetes team, and most of the time we follow them up at least initially once a week, then once every 2 weeks, once every 4 weeks, based on the diabetes control, based on the hypertension control. And of course, if they are non-diabetic, what was their HbA1c or A1c prior to getting pregnant and during the pregnancy? And also, are they known to have diabetes-related complications such as nephropathy, retinopathy, or not? And with that, we follow them very closely. But if they are presenting at 39 weeks pregnant, they are not being under a joint team, it becomes a problem. We have to know what's the diabetes control, what's the hypertension. But I expect that if this patient was under a joint team, would you have known about their diabetes control that maybe is very stable? Would you have known about their blood pressure? And based on, in terms of retinal screening, we tend to do retinal screening for type 2 diabetes patients who are non-diabetic. If they don't have history of retinopathy, they can have retinal screening in the first trimester and the third trimester. But if they are known to have already existing retinopathy, then they have retinal screening in the first, second, and third trimester, and we have to optimize their blood pressure. Because the patient comes with back pain, I think Dr. Gabon sent a note in terms of maternal fetal index, in terms of trying to stratify the presentation of the patient and what kind of category in terms of, are they a start as urgent, they need to be seen now and be admitted to labor ward? Are they just urgent? Are they a priority or non-urgent and so on? So for the first patient, it will depend upon if the patient was under the team, a joint team, long-term, and would have known about their problems. And if this is a new problem, lower back pain, what's really happening? I think this patient falls under the category of being urgent and not start, is not number one priority. But we will still assess this patient and make sure that they are seen. And if they are non-diabetic, normally, we don't go beyond 39 weeks to deliver. So I will still say that this patient is near the time, because she's non-diabetic, she might need to be admitted to labor ward and be assessed whether, are we gonna try and assess why she's got pain, what's the blood pressure, and is it time for us to deliver the baby? In terms of the second scenario, maybe if you remind me, what was the second scenario?
Oh, the second scenario is the G3, P2, and at 32 weeker, history of preeclampsia, rupture of membrane at 12 hours, clear fluid, temperature 101, and she's complaining of contraction every 2 minutes.
So if I've seen in the setting of antenatal clinic, we see them once a week in our setting. So when they come to the clinic, they'll be coming for their normal appointment. If they come and present with that presentation, almost always admit them and monitor them and assess them in terms of what is really happening. And that's where my colleague from obstetrics will deal with the patient. But my input as a medical physician, I'm also there to make sure that, are they hypertensive? Are they diabetic? Is the diabetes control optimized? And I don't know what is the your side, but for this side, I know that if someone is diabetic, like for the first patient, their glucose levels readings before meals should be between 4 to 5.3 millimoles per liter. That is, we're using different readings. And 1 hour after meals should be between 5 to less than 7.8. So we tend to monitor that way and make sure that that's a better control. It's in daily monitoring. And with advancing technology, now we're using continuous glucose monitoring for our patients. Almost all my pregnant women, the type 1 diabetes patient, they're on Dexcom. Some of the type 1 and type 2 diabetes patients who are pregnant were using the so-called freestyle Libra or flash glucose monitoring, and we get their readings remotely. So some of them, we call them that your control is very bad. But in summary, I'll stop there saying that for the two scenarios, yes, I'll be involved as a physician, give my input in terms of hypertension, in terms of diabetes. And for the second scenario, yes, if they are seen in the clinic, they will be sent to the ward straight away and be on continuous. They're being monitored regularly, especially the fetal heartbeat and the mother as well.
Okay, thank you very much, Dr. Mlawa. We're gonna come back for the medication part, what you do or recommend after that, once we hear how other people arrive that patient, or from our triage, maternal fetal index, they said how we received that patient. Okay, I'm gonna go to Dr. Mugalu. So you heard the response for Dr. Mlawa, and then so in Tanzania, with those two patients, you can pick one of them, you can answer for both, that's fine. What things that you will add to it, to what Dr. Mlawa has said, and then so we can learn from what you guys do in Tanzania.
Thank you. In Tanzania, when we receive the first woman, the Gravida 2 para 1 at 39 years old, she's already in labor. So when we receive her, when we receive her in the maternity block, first we'll do the same as he said. We'll try to check the blood pressure and the random blood glucose. Then we will try to ascertain if the woman had them before getting pregnant, or these are pregnancy related. We'll initiate medications appropriately, but this woman will be categorized as a high risk patient. We have the screening chart, which is the same as the AFOG chart, pasted in the maternity block, so we can classify the women as high risk and low risk. So if she's a high risk patient, which means we will be doing more regular follow-up than a normal patient. So we'll monitor fetal kicks every 30 minutes to 1 hour. We'll check the blood pressure and we'll check the blood glucose to see how the medications are responding. In the second patient, she's Gravida 3 para 2 living 2 at GA of 32. She's presented in labor and she's preeclamptic and she has pre-labor premature rupture of membranes. Such a patient, when they come first, she has had rupture of membrane for 12 hours. So our approach is we give them broad spectrum antibiotics. We usually start with intravenous ampicillin, and then we go to oral, erythromycin and metronidazole. But we also give them dexamethasone for lung maturation, and then we'll do an ultrasound to see how much amniotic fluid is still left, and we'll do a fetal scan. And after that, as we can see, the labor has progressed so much. So just go and deliver, but this patient will most likely end up with a referral due to premature care.
Okay, excellent, Dr. Mgao. Thank you very much. And I know you touched quite a bit of the medication and the ultrasound screening. We're going to come back with that part because I want to make sure the other people speak on it for those two patients, and then we can come and actuate the intervention part. So thank you for sharing that part. And you said the Afro chart, so high risk and low risk, and then you escalate the care according to the patient acute. So that's excellent. Thank you. I'm going to go to Dr. Emma. Let us know what you guys do in North Carolina.
Yes, I think we do something very similar to what the other two doctors said.
Okay.
So when the patient comes in, I'll refer to both of them. I think very important for you, the provider, to get the history from the patient. Okay, so she's had several children before, were they by C-section or were they vaginal deliveries? Because, you know, if they've had a prior C-section, that will increase their risk of postpartum hemorrhage. You want to ask them if they have any history of fibroids, for example. You want to ask if they have had any problems with the placenta before. So try to get as much history as possible from them. And then you want to do a good physical exam. So what is the mom's weight and height? What is the BMI? As we know, the body mass index, the higher it is, also the higher the risk of postpartum hemorrhage. You want to see, is she actively bleeding? If she's actively bleeding, that puts her already at the high risk category. And then you want to check her blood pressure. Is her blood pressure high? That also can increase her risk of postpartum hemorrhage. Ultrasound, very important. You want to do a quick ultrasound and look in there. Does she have two babies? What a surprise. Does she have twins? That will increase her risk of postpartum hemorrhage. Where is the placenta? How about the fluid around the baby? Is it a lot? Does she have one of those polyhydramnios where the uterus is overdistended, and therefore that also increases her risk of postpartum hemorrhage. So I would do all that, and then I would move on maybe to doing some blood work. Definitely you want to do a CBC, complete blood count, and see what is her starting hemoglobin. Is it already less than 10 or less than 8, which also elevates her risk of postpartum hemorrhage? And what about her platelets? Are they normal or are they low? If her blood pressure is high, maybe I would also check for things like preeclampsia, because also preeclampsia increases her risk of postpartum hemorrhage. So that would include also doing like a complete metabolic panel, maybe like a urine protein creatinine ratio. So I would do all those things. There is a system at the hospital where, depending on what you find out, from the history and the physical exam and the labs, you can enter those details in the computer, and the computer will actually add everything up and kind of give you like what is her overall risk of postpartum hemorrhage. As you know, there are different risk factors for postpartum hemorrhage. Some of them put you at a medium risk, some put you at a high risk. So, and then if somebody has 2 like medium risk factors, that automatically puts them in the high risk category. So we do have a good system that kind of takes off a lot of the effort in calculating. It just kind of tells you automatically high risk or low risk. And then if they are medium risk, for example, this is the kind of patient that you also want to order a type and screen for her. And also you want to alert all the necessary people who need to know, like maybe the charge nurse, maybe the anesthesiology, just in case there is any postpartum hemorrhage. If they do turn out to be in the high risk category, then you also want to get like a type and cross match. You may want to order like already 2 units of blood on standby. And then depending on if, for example, you think somebody has an accreta or a placenta previa, you may even go ahead and order like platelets, FFP, just to be on standby. And definitely you want to alert the charge nurse, the anesthesia team. You probably also want to have the patient have 2 large bore IV access lines. So you just want to be prepared from that standpoint. That's what I would do at my practice. Yeah.
Thank you very much, Dr. Emma, and thank you for the details. And then the tool. So yeah, you're right. A lot of digital word support we have now, and it adds all these tools to be able to help. Definitely that adding the values, and then you get the score. It does screen and system add a consistency between providers, which is great. So at least and then of course working with the nurses. So by seeing those criteria and those identification, then for sure, okay, this patient needs A, B, C, D. And then regardless of which provider is there, so at least that patient is going to get a consistent care. So that is an excellent discussion there. Thank you. So I'm going to go to Dr. Nestor after I ask Dr. Kristen, because I'm going to ask Dr. Nestor almost like 3 questions from previous providers for you to fill in that part. Dr. Kristen, what have you seen first the patients who with similar history, and then what did you guys do in China for your experience? I know you said your 2nd year, but I know you've had or seen this patient a bit more. And then I'm going to go back to Dr. Nestor. Dr. Kristen? Oh, I think we lost him. Okay, Dr. Nestor, go for it. Sorry. I know you had the other doctors have shared how they screen or even just some of the process that they do. And then so from your standpoint in Sweden, anything that you can add, and then, I think 2 of them have mentioned the ultrasound, which part of it you can fill in and give us what you guys gained from doing the ultrasound. And then patient experience too. Yes, go for it.
Thank you. The other fellow doctors have already discussed, I would just like to add to their discussions from very good discussion from the medical point of view, Dr. Mlawa, and from Tanzania, Dr. Mugalu, and even Dr. Emma. She has already mentioned a lot of risk factors and how to screen. So I think we do similar, but what I can say in Sweden is like these women, they have, when they come to me in labor ward, the one with the hypertension, diabetes, and the one with preeclampsia, and even rupture of membrane, premature rupture of membrane, we have already their very detailed antenatal history. It's already written very well. All the risk factors, they are already documented. So you know if they have they have delivered before, by which method, you know already the amount of blood loss, you know already in their journal, antenatal journal. So so you take from there, you know already their history. You don't need to ask a lot more. You can ask the presence, the situation which the patient come with now. You come with this kind of okay, because I already know you lost maybe 3 liters during your second delivery, and it was cesarean section, and it was very difficult to remove the placenta and something like that. And during this pregnancy, they have maybe already screened this woman, even in LA. We do ultrasound, early ultrasound at week 11 and 13. This is called the very early ultrasound. And the other ultrasound is week 18 to 20. This is like a routine ultrasound. During this kind of ultrasound, they only screen for the placenta previa and even abnormal placentation, especially for the women who has a history of like postpartum hemorrhage, who has a history of cesarean section, or during the screening, if they, even a woman without any risk factor, but they find it to see the placenta is low laying placenta, then they can do the further screening, maybe the vaginal ultrasound to rule out where the placenta, and even sometime if it's needed, they can do the MRI. This is to rule out the abnormal placentation if it's like a suspect of like placenta pancreata or increta and something like that. So so many risk factors have been mentioned by Dr. Emma. So I'll, from my point of view, when I work at a hospital which is the largest one in Sweden. They have like 11,000 delivery per year. So we have 3 delivery.
That is a lot of babies.
Yeah.
That's a lot.
That sounds like a little factory.
Exactly. So we have 3 like delivery department. Like there's special delivery for the cases, for the special cases. All these cases will be put in for the high risk mothers. They will be put there. And when we work like night shift, we are 4 doctors, and 1 doctor is in the normal delivery, 2 doctors in the normal delivery, and 1 doctor in this, who must be a specialist in this one. Specialized delivery, where they put all the high risk mothers, and 1 doctor at the emergency receiving patients. So and from there, they will also do all the screening. Mostly we normally do we check the history, we do the ultrasound. We use we use ourselves ultrasound. We have ultrasound everywhere. So an obstetrician is the one who is doing the screening with the ultrasound. We don't send a patient to a radiologist or a sonographer or something else. We are the one who are doing the ultrasound. So you do the same procedure like Dr. Emma has mentioned to try to rule out abnormal placentation, rule out if the patient has pain, to rule out ablastio placenta, maybe little placenta hemorrhage, and things like that. And so ultrasound is a very important tool in in making diagnosis for the abnormal placentation, and even especially for the women who has many risk factors, especially the one who is multipara woman, women with BMI more than maybe 30, women with diabetes who are likely to have macrosomic babies. They have also risk factors for bleeding because of atonia and things like that. So yeah, we will do basically the same, and we will be prepared. Prepared, it means like if we know that this woman is has an invasive placenta, then we are sure that she come in labor, then you cannot go to theater by yourself. There is a team of doctors. It's a team of maybe 5. They normally like team of 5 people: urologist, gynecologist, maybe 2 very senior obstetrician, anesthesiologist, and even anesthetic nurses. They are gathered together and do the procedure, and they can stand together even a few minutes before the procedure and go through what they are going to do. And if it's very emergent, like ablastio placenta, then we know that by ultrasound we have already diagnosed. We make a diagnosis, but clinically we know that this is ablastio placenta. Then we talk to even the hematologist. Sometimes we send a lot of samples to rule out the to see the coagulating factors, like the activities like the PT, APTT, fibrinogen, antithrombin, things like that. They are already, and we are prepared that this patient might have lost a lot of blood and might have a high risk to develop DIC. So we are already prepared. The anesthesiologist is prepared. There's a lot of blood sample prepared in case we need to transfuse this patient, and things like that. And the other thing is the thrombocytes. If it's in case of the case with the preeclampsia, sometimes they have low thrombocytes, then they can get transfused the thrombocytes before even delivery, so that to make sure that we reduce the risk for them to bleed more or postpartum hemorrhage. So basically we do the same thing, but the preparation is very, we don't need like to be surprised. Most of the people don't need to be surprised. So you go to the theater, you know exactly what you are dealing with. Even though you know what you are dealing with, these women bleed up to 4 liters.
They do. When they decide to bleed, they bleed. Thank you very much, Dr. Nestor. I'm just going to have probably a couple of questions follow up, and then I'm going to ask the other doctors to jump in and respond. So for this first scenario, the G5 P3, so if the mom comes in, she doesn't have a prenatal care, how accurate the ultrasound is to tell us maybe what are those things you are discussing? How accurate is it? Can we rely on just the ultrasound, or should we have other assessment tools to make sure we prepare for this mom?
Yes, ultrasound is one puzzle, is one tool in the management. Like I said, like Dr. Emma said, like you rule out the abnormal placentation. If it's placenta is like anterior and is low laying, then you can do also transvaginal ultrasound to rule out if it's like a total placenta previa, something like that. And if you rule out maybe even vessels who are passing through the internal os, maybe vasa previa and things like that. But if you suspect things like that and you're sure this is a low laying placenta, then yes, you know what to do. You are not going to allow this woman to deliver vaginally. You are going to do cesarean section, but you are going to be prepared, because this woman has hypertension and has diabetes, and she has a very high risk to develop preeclampsia. So you do also the screening with blood sample, like renal function test, the liver function test, the blood status, to see if she has low thrombocytes and things like that, if she has elevated liver enzymes or elevated creatinine and things like that. So you rule out if she's like already toxic or like affected with the high blood pressure. She's likely to, maybe she has already developed preeclampsia or not. And the other stuff that you rule out is like if she's no antenatal care, that means she has never attended the antenatal care. I don't know.
Yes.
It is very unlikely in Sweden, but it's most likely in Tanzania.
Yes.
But you can do exactly the same procedure. Some patients who have exactly migrated to Sweden and they have not maybe managed to attend to the clinic, and they can come with maybe a paper from where they come from, and you can read and you can complete the history by yourself. All those stuff Dr. Emma mentioned, you just complete the history and you know what kind of a patient you are dealing with, plus your examination now.
Okay, excellent. Thank you very much, Dr. Nestor. I'm going to go back to Dr. Mugalu. I know your hospital in Mwananyamala does have the ultrasound. So help us understand for the hospital, for example, if you have any information for the hospital that do not have ultrasound in Tanzania, what are the things that are readily available to them for them to be able to screen? Because everybody has an excellent response, and what are the process you are doing? So let's go for the people who do not have, or the hospital that does not have in Tanzania, all those resources in front of them. Still, they should be able to do the screening the same and hopefully prevent the severe postpartum hemorrhage. Dr. Mugalu?
Thank you. So at Mwananyamala, we do have an ultrasound, but unlike Sweden, it is done by radiologists. So there's just one ultrasound department for the whole hospital. And it is a referral hospital, so the hospitals surrounding it, not all of them have an ultrasound. So they have to rely on physical examination. We do abdominal palpation, we take proper history, and we do the vaginal examination. We mostly rely on physical examination.
Okay, excellent. That's what I wanted to make sure you can help us with that. So thank you. Dr. Mlao, do you want to add anything to what the other panelists have discussed?
I think what the other panelists have just discussed is, I think it's a very excellent discussion, getting experience from Emma in the USA, then from Sweden. I think me as a physician, as I said from before, that if we see these patients in antenatal clinic, we make sure that they go to labor ward or they go to triage unit and they end up in labor ward. But also in our setting, we have got the triage system using community-based and acute-based, acute care. So the two cases are mainly acute cases. And our patient who is type 2 for sometimes will be known to us, and we'll always almost know if their sugar levels is not doing well during their visits and follow-up. And with this presentation, almost always we make sure that they're admitted. But let me add what Dr. Nestor has said, the role of multidisciplinary team. I think he put it very well that everybody's involved. That's why you can get a physician within obstetric ward, and my role will be to say that, is this patient now hypotensive, tachycardic? Have they lost blood? Do they need blood transfusion? But also the hematologists are involved. It's very important. We get anesthetics who are always around, and ITU or high dependence unit team because these patients, when they come to the ward, some of them will end up in high dependence unit, be labor high dependence unit or general high dependence unit, but working together as a team.
Excellent, Dr. Mlawa. Thank you very much. Definitely, the role of the multidisciplinary team is required, not even needed, just required, because we do have, I mean, everybody have their expertise in the specific area when we do work together, so you can complete that puzzle, like Dr. Nestor was saying, complete that puzzle and then work as a team to be able to help. I like when he said sometimes you pre-brief before you do that surgery, especially for somebody with a creta or increta. So you know for sure this patient is already at risk just for having that history, even before you deliver. So having the strategies to have that plan in place, definitely we're going to use that complication. Yes, Dr. Emma? I see your hands is up.
Yes, sorry. I was just going to add on to what everybody else said as far as the ultrasound is concerned. Yes, ultrasound is very helpful in these types of situations. And as we all know, ultrasound is safe in pregnancy. It's very quick to do. At my hospital, we do have ultrasound that's available on the unit and can be dragged around very easily. Anybody can use it at any time. And a lot of the OBGYNs will do quick ultrasounds, you know, check the presentation of the baby, check the placenta, what is the estimated fetal weight of the baby, how much fluid is there. So it's very helpful to have that available. We do have the radiology available too, but that's usually for like patients who are not in like an acute state, like somebody is just going to see what the estimated fetal weight is, she's stable. So I think having an ultrasound available on the OB flow would be very, very helpful in these types of situations. And the training for the ultrasound, or at least I got my training when I was doing my residency, where you basically, when the patients come in, you are like learning as you are doing your residency. The attending doctors will show you. And also we did spend some time with the radiologists. So I feel like it's something that's very easy to learn. I don't know if there's any formal training programs on ultrasound in Tanzania, but that's something that the OBGYNs could look into.
Thank you very much, Dr. Emma. Dr. Mugaro, can you help us with that? How do you guys get, oh, you did say radiology does in Tanzania, right?
Yes, in Tanzania, the radiologist does it because we only have one ultrasound.
Okay.
So for an acute patient, we mostly rely on physical examination. So, you know, the patient presents with PV bleeding. We try to take the history. Is she in pain? Is she not in pain? So the main cause are usually just two: the abruptio placenta and placenta previa. So if they have painful bleeding, the abdomen is tense, we go forward and ascertain that it is abruptio placenta. But if they are having PV bleeding, but they have no any other pain, we go ahead and ascertain the placenta previa, and then we do care appropriately according to each diagnosis.
Thank you very much, Dr. Mugaro. Dr. Daniel, you raise your hand. If you can introduce yourself and then provide your expertise, please. Dr. Daniel. Unmute.
Hello, can you hear me?
Yes, we can. Can we see
so
you?
I'm okay. I'm Dr. Daniel Michael, working at CCBRT. I just want to give my experience with ultrasound. So the ultrasound, I remember I did training also when I was resident. Also, some universities here in Tanzania, they do provide you see, basic ultrasound training for their residents. So I just want to also to make that, you see, to create also awareness, you see, on that. And most of the time also is very helpful because sometimes you can get an emergency at the middle of the night. and sonographer is not there. Also, you can be monitoring a patient, you see in labor ward, and fetal heart rate are not sure if they are there or not. So if you can do quick ultrasound, if you as obstetrician or doctor, working in labor ward, can help, making a decision by knowing basics of ultrasound. Thank you so much.
Thank you very much, Dr. Daniel. So anything on the admission and screening? Do you do that too?
Yes. So yes. So when patient she gets admitted, or maybe during admission, so we do screen for if she's having any chronic conditions, or the clinical condition of the patients. So through that we can do triage and also do prioritization, depending with the patient conditions.
Okay.
Yes.
Excellent. Thank you very much for joining us, and then thank you for sharing your input in there. Okay, we can go back to Dr. Mlawa. Yes, I know one of your area of expertise, one of many, the diabetic, of course. So with this mom who is 39 weeks, I know usually the diabetic patient, you guys don't let her go all the way to 39 and 40 because other complications will happen. I just put in that just to make a little bit of exaggeration of the symptoms. But anyway, for a diabetic patient, so let's say she A1B is, I don't know, 10, 12. So what are other things that you could add before you deliver this? I mean, before you let your colleagues, OBGYN, deliver this mom, what else things can you do?
I think for this patient, because she's non-diabetic, and if she's got very severe hyperglycemia, the risk is, we know that once we deliver a baby, there's risk of neonatal hypoglycemia. So we have to try and optimize her care. So if she was not known to, she was not seen or followed up properly, we have to make sure that at the time, we have to make sure that we get better diabetes control. Is that the question is, are you going to start her on insulin straight away? Are you going to put her on insulin infusion? The aim is to make sure that you get near normal glycemia at the time of delivery, because the baby or the fetus is depending upon the maternal glucose through the placenta. And if you cut the cord, once they're delivered, there's a risk of neonatal hypoglycemia and therefore neonatal maybe seizures. And these patients, these babies end up in neonatal intensive care unit, or we call it NICU in this part of the world. So we always try and make sure that we're involved in terms of getting better control. If she was not known being on anything, we have to make sure that I expect that if she was type 2 diabetes, she would not be on any other hypoglycemics apart from oral hypoglycemics apart from metformin. And then we can add insulin. But in our setting, we would expect her to be under our care. We'll know their diabetes control up to the time of delivery. And we normally, we plan delivery at 36 weeks. So when they come at 36 week antenatal, joined antenatal diabetes care, there's a plan of delivery is given to them, and the elective admission is arranged for them in this setting. So in summary, we should be getting to make sure that their diabetes is well controlled to avoid neonatal hypoglycemia. And because it's a very late presentation, the neonate need to be monitored closely before being discharged.
Okay, thank you very much, Dr. Mlawa. Question goes to Dr. Emma. So this patient, yes, 39-weeker, and I know we don't get them that close, but anyway, even you 38-weeker diabetic, and would you rather deliver her vaginal? Do you deliver C-section? Minus the position or the size of the baby coming out, but it's just like if we prefer, when we're thinking of prevention of postpartum hemorrhage, would you prefer her to be delivered vaginally or C-section, Dr. Emma?
Okay, that's a great question.
I would say that even with the diabetes, even if it's not well controlled, I would still offer her a vaginal delivery, especially if she comes in and she's stable, assuming that she's coming in and her sugars are, within like normal range. They're not too high. And also when we do the fetal monitoring, it looks like her baby is doing well. And so if she's clinically stable, I would still offer her a C-section, a vaginal delivery, sorry. Of course, if maybe the ultrasound showed that the baby was macrosomic or ultrasound showed other features that were concerning, then I would offer her a C-section. But if mom is stable, baby stable, we're kind of managing the sugars well, then I would still offer a vaginal delivery. And this is where also Dr. Mlawa, just like he said, optimization of the patient is very important in the prenatal period. But also a lot of times we will have the endocrinologist suggest for us, like when the patient comes in labor or comes in for the induction of labor, how should we manage their diabetes? So a lot of times we will have detailed directions on how to approach this. So it's always helpful to have the medical doctor's input in these types of situations.
Excellent, Dr. Emma. Thank you. Let's go
I'm
to...
sorry, and I just wanted to also add, if you think about it, if you're going to do a C-section on somebody who is not well controlled with diabetes, or even somebody who has diabetes, we also know that they do have a high risk of post-op infection, poor healing. So I think we always want to try to have a vaginal delivery as much as possible. A C-section is not always the best option unless you have good indications for that. Thank you.
Thank you very much. That's the reason I asked that question. Because sometimes people be like, she has the diabetes straight to C-section. I'm like, why?
Yeah.
I mean, this is the baby's a CPD or something. I'll be the first one to say good. But still, I mean, like, think of all those factors that you think, okay, C-section, yes, she is not going to heal that fast. Yes, Dr. Mlawa, can you see?
That's what Dr. Emma said, because I'm talking on behalf of my colleague from obstetrics. Whenever I sit with them in a clinic, because we sit in the same room, I listen to them when they talk to the patient, and some of the patients will come and say that I want C-section. Some of them, they say that, okay, I want a C-section because
they talk to each other, yeah.
So with that, I think my colleague have told them that, okay, as Emma said, that maybe there's risk of, it's high risk, it's an operation at the end of the day. But if, for instance, this is for this patient, that's her first baby, it means that the future pregnancies will need C-section, and it becomes a high risk pregnancy. So I'm just adding what I hear from my colleague from obstetrics, and I think it mirrors what Dr. Emma just said.
No, I agree with you. Sometimes you hear the discussion, you'll be like, no, what about this? So thank you. Dr. Nestor, if on your part, what have you seen delivering parts? I mean, a diabetic patient, yes, either controlled, uncontrolled, and then do you lean towards the C-section? Do you try and go for vaginal delivery? And what are the other things that you can add to it to help your decision, one or the other?
Thank you. I think Dr. Mlawa and Dr. Emma, they have already clarified it very well. But our routine here in Gothenburg is like there is already a delivery plan, like Dr. Mlawa has said. There is a delivery plan at week 36. As an obstetrician, I meet these patients to do the weight estimation every 4 weeks from week 28, 32, and 36. And I do the delivery plan at week 36. All the women with diabetic mellitus type 1 or with gestational diabetes who need medication like insulin or metformin, there is a plan. And there is also a very like detailed plan from the diabetic nurse with which during the delivery, because they have highly the need of insulin is yeah, they know that during labor they have they have planned exactly what kind of insulin they are going to get, what short-acting insulin, in which doses, and what is the target blood sugar level. Everything is written there, so the plan is there, and this woman is going to be at the specialized delivery unit. So for me, as an obstetrician, is easier in that part. But like Dr. Emma said, mode of delivery for these women, if there is no other contraindication, is vaginal delivery. If there is no other history of C, and we normally do, like during the delivery plan at week 36, you plan induction. They don't have to go. They don't have to pass expected delivery date. This woman should be induced. If they have not come with spontaneous labor pain, they have to be induced at week 40 plus 0 or 39 plus 6. Both patient with the pregnancy-induced hypertension and patient with the diabetes mellitus, type 1 or type 2. If there is nothing else that has worsened, they have to go to week 40 plus 0. But if there is any challenges during monitoring of the blood sugar and things like that, then you can induce them depending on the condition. There will be weighing between the risk and the benefits of the mother and the baby. Yes. So yes, mode of delivery, vaginal delivery recommended first.
Okay, thank you very much. Dr. Mugalu, I'm going to go back to you, and then next is going to be Dr. Daniel. So Dr. Mugalu, what are you guys recommends or leaning to, and what are the reasons you do that? C-section vaginal delivery.
My fellow doctors have explained, well, we do the same thing.
Okay.
So when they're diabetic, most women, we prefer vaginal delivery unless there is a complication.
Okay.
So if as they previously explained, there's microsomia, the mother has a previous scar, she's bleeding, there's fetal distress, there's severe maternal exhaustion, and then we'll do the cesarean section. But if the mother and the baby are stable, we go for the vaginal delivery.
Okay, excellent. Thank you, Dr. Mugalu. Dr. Daniel, what about your CCBRT? What do you guys do? What are you leaning to? Dr. Daniel, maybe unmute. Okay, so we can come back. Okay, so we have seen what we can do for these moms in terms of screening them when they're coming to triage. And then I know half of you will express what your plan of care for this mom. And then so now, let's say the same mom that with those symptoms that you have identified on admission, now you're planning for postpartum hemorrhage. Are there things prophylactically you do to prevent that postpartum hemorrhage? Because I mean, for the diabetic mom, we already discussed all those risk factors. So what are the things that you do a little bit different now? You're getting close to the delivery and then you're anticipating this mom is going to bleed. What are the things can you do? We can start with Dr. Emma, sorry.
Yes, so I think if you are concerned about high risk of bleeding, then you definitely want to have your medication agents readily available in the room. So maybe this is the kind of patient that I would tell the nurse, have the Pitocin ready to go, for as soon as the baby is delivered, that we're going to start it. I would also advise the nurse to have some methadone in the room, maybe some tranexamic acid available, and maybe some Hemabet and Cytotec. So all those are available in the room. And so as we progress to delivery, hopefully she delivers vaginally. And as soon as the baby is delivered, or even as soon as the anterior shoulder is out, Pitocin is getting started. And that can continue until, I guess, see how the progress goes. If it looks like baby's delivered and now maybe she's having some atony and bleeding issues, then I would call for the other agents. Like I said, the tranexamic acid, the methadone, the Statotec. Of course, I would be doing a good fundal massage. I would check for any other potential causes of the postpartum hemorrhage. Does she have any lacerations that need to be repaired? I would take care of that. I would check the placenta. Is the placenta completely out of her, or is there any retained products? If so, then maybe I would do an ultrasound again and look and see, do we need to do like a DNC on her to remove everything? So I would definitely have my medication ready to go.
Excellent. Thank you very much. Dr. Nestor, anything that you can add that you do prophylactically before she deliver and start bleeding on you?
Yeah, this is more similar to Dr. Emma. It's the same, like you prepare the medication, you are already prepared. You have a patient with diabetes type 1 and even a patient with hypertension. Then you already discussed this woman should not receive methadone because she has hypertension, which is it will worsen the blood pressure. So, but all the other medication, concentrated oxytocin, misoprostol, tranexamic acid. If with cesarean section, then tranexamic acid should be given even 1 gram IV or 2 gram IV before even you start the operation to prevent it minimize the bleeding. And the things, some patients is like patient with asthma, then you discuss already, this patient should not receive carboprost, which is another medication, which is uterotonics. So you discuss even the risk factor of the medication. Which one are we going to give? Which one are we not going to give? In case we have a severe postpartum hemorrhage or postpartum hemorrhage. And the nurses, they are prepared also to be active in the second stage and the third stage of labor, to be very active. And in case of minor suspect or retained product of placenta, then you go to the theater to do the evacuation of the uterus manually to see if there is a possibility of retained. You don't have to wait if you have a high suspect of postpartum hemorrhage patient. You don't have to wait longer, like maybe when a patient has already 500, 600 milliliter bleeding, and then you see like, okay, we are not sure about the placenta, then you go to theater, or someone can do the manual exploration of the uterus to rule out a retained product of placenta in order to minimize the blood loss. Yeah.
Excellent. Thank you very much for that detailed response with the medication. Definitely, in selecting the medication, what are the things that we need to put in place? Appreciate that. Dr. Emma?
Yes, I was going to say those are great points from Dr. Nestori. You definitely have to keep in mind the contraindications for the different medications, because you don't want to make things worse by giving somebody who has hypertension methadone. Then that's not good practice. So thank you for bringing that up. I also just wanted to add, of course, at some point, if somebody is bleeding heavily, you may also consider giving them like a blood transfusion, especially if it looks like they are maybe in the third stage of postpartum hemorrhage and their vital signs are unstable. But also important for you to clarify in advance, is this one of those like Jehovah's Witness patients who will not accept blood transfusion? So when they come in, I think we also have to clarify these issues with them. Like, what if we had to give you blood? Are you okay with that? So we know in advance. And so with these types of patients who will not accept blood, then you definitely want to have other options available, like the albumin, extra IV fluids. And these are also the kind of patients that you may intervene more in other ways. If the medication is not working, take them to the operating room, maybe consider those balloons to help with compression of the uterus, maybe even have to do compression sutures. So you also have to know what will the patient accept and what will the patient refuse in these types of situations. So preparation is key in advance. Thank you.
And thank you very much. You raised a great point right there, Dr. Emma. Thank you. Dr. Mugaro, do you have anything to add there, or Dr. Mlawa?
So I think coming as a medic, what I know, we see a lot of patients in antenatal as a part of preparation, as a part of optimizing them. We then monitor different blood tests, including hemoglobin. If they are already anemic, the majority of them are iron deficiency. We know that they've got a group and serve which is ready. And I think prior to being induced, or if before delivering, we try to give IV iron infusion, the so-called monofar. So I've got a few patients where we see them, we assess them, and we think that they will be delivering soon and they are anemic. We give them iron infusion, and also they will continue on iron tablets as a part of optimization and hoping that they don't bleed, or if they bleed, at least they've got some reserve of iron in them. And what I know from this side, I think for us, even for someone of childbearing age, we are very careful in terms of them just giving blood transfusion because of formation of antibodies. So we always try to hold up to, unless it's life-saving thing, then you can give blood transfusion. But we always involve everyone, including the hematologist.
Excellent, Dr. Mlawa. Thank you very much. Dr. Daniel, do you have anything to add? And somebody's on the iPhone. I'm not sure who it is. But Dr. Daniel, do you have anything to add there? What leads you guys in making a decision, C-section, vaginal delivery?
Yeah, thank you so much for this opportunity, and I think I'll point out on if you have a patient with a risk of PPH, she may be in labor ward. So the first, the first thing is to prevent PPH by preventing anemia itself, and I think after delivery, then the patient here in practice, sometimes, so we give misoprostol, parenteral, or sometimes you can give IV oxytocin, like 20 international units, which runs like 2 to 3 hours after delivery. So those are the few things to add if you have a patient with a risk of PPH, like from the practice point of view.
Okay, thank you, Dr. Daniel. I know somebody's on the iPhone. Any questions, comment? No? Christy, any question, comment? Alisa?
No, none for me. Just
Okay.
soaking up everything.
That's good. A good review, huh?
Yes, very much.
Good. At least I'm going to be answering this question on Wednesday on the final exam. So thank you to the doctors for sharing their content here. Okay, so we're just finishing up with the last question, and then we'll be finishing the training. After the delivery, so what other tools do you use to say, okay, this patient is bleeding too much, let me start activate or initiating postpartum hemorrhage protocols? So do you estimate the blood? Do you quantify the blood? Why and why not? Let's start with Dr. Mugaro. What do you think?
Yes, first I would like to add on the first point of discussion that we had. At my current hospital, when we have a patient that we anticipate might get a postpartum hemorrhage, We ensure that the patient has double cannulas, large bore cannulas. And since we prefer spontaneous urine urination, so for a patient with a risk factor, we make sure she is catheterized. But we also order the same medications, tranexamic acid, misoprostol, and oxytocin. And as Dr. Daniel said, we give them the dose in the 10 international units in the third stage of labor. But after delivery, we also keep infusion of oxytocin, which runs to here we do 2 to 4 hours with 20 international units to prevent PPH. So coming to the question of how do we quantify blood loss? How do we decide a patient has PPH? Mostly we do visual estimation of PPH. So we have a chart which shows we have the kidney dish. There's a 500 mils and the 1000 mils kidney dish. But we also have a chart which shows if blood is around the bed sheet, this much is 1000. When it goes up to the floor, this size is 2000. When it is 100 centimeters radius, this much is 500 mils. So we have visual estimation.
Okay, thank you very much. That's one of the area that when we come to Mwananyamala, one of the training area from the Qhsc is to at least work with you guys to try and encourage quantification of the blood loss. So we are going to, for the times that 4 days, we're going to be with you guys. For the time we're there, we want to be able to work with you and try to get quantification of blood loss. You can still continue visualizing, so then we can compare those data and just try to find the best option and give you an extra tool to be able to say, okay, this is the patient is getting worse, so they're moving from one stage to the next if you're using those staging for the postpartum hemorrhage. And then so you can speed up or escalate care on the patient, which you guys are doing excellent already with your visual assessment. But yeah, so we're going to try and do that little project with you guys and hang out with you guys a little bit longer, so to be able to increase the possibility of quantification of blood loss. Yes, Dr. Mgalo, do you?
So visual, that will be very helpful, since most of the times visual is depending on the practitioner who was at site. Visual estimation usually leads to underestimating the amount of blood loss. So
that's an excellent point. That's the reason that we are trying to do the quantification. So yes, I'm so happy to hear that.
Yes, but we also rely on the vital signs and the patient's condition.
Definitely, yes, definitely. Excellent. Dr. Nestor, estimated quantification.
Yes, I'll add from Dr. Mugalo where she ended. The first thing is they normally, you have the midwife, you have an assistant nurse. An assistant nurse in the labor ward, she's measuring the amount of, there's a weigh machine in the labor room where she can take all the gauze, all the tissues that have been soaked with blood and measure and deduct the actual weight of the tissue and get the estimated amount of the blood loss. So she normally tells us, okay, now we are up to 600 milliliter loss. Now we are about 1 liter blood loss. So that is one perspective. The other thing is that she's also taking the vital signs during the procedure. When the other one is like holding the outer compression, the other one is giving the medication, longitudinal cannula. She's measuring the vital sign and telling us the vital sign. And the vital sign tell us also, okay, now this patient needs to go to theater. We cannot stay with this patient in a labor room who we suspect she has lost more than maybe 1.5 blood loss. And we are not able to control the bleeding in the room. But if we have already managed to control the bleeding with the management that we have given, then we can live from there and continue with close monitoring. But otherwise, if we see that we have not managed to monitor the blood loss, and we have not corrected the causes, then if there's a possible way, this patient has to go to theater where there is an anesthesiologist and other team which can support us in caring the patient. But yeah, the same like Dr. Mugalu, vital sign very important, but we have a weighing machine that we measure. We don't estimate like, okay, even in the theater room, they have they have this weighing machine where they can measure all the gauze, all the tissue that have been soaked with blood and get estimated. So we normally rely on that.
Okay, perfect. Before I go to Dr. Emma and finish up with her, I'm going to Dr. Mlawa. I know you are in the, not in the actual delivery room, but what do you guys do at your hospital, if you know, estimated or quantification, and if you know what the reason they do that?
I think for us as medics, we're always involved. If someone is in labor ward, hypertension, they're bleeding, we put the point of care in terms of doing, you can do VBG or blood gas, venous gas, to tell you that, okay, the hemoglobin is now 60, but it was 100 just maybe 24 hours ago before start labor, and that tells us that somebody is maybe losing more blood. Also, together with the vital signs, are they more tachycardic? Are they more hypertensive? So my medical team, as a part of the medical team, I've got a medical registrar. The training registrars, they go everywhere, including labor ward if they're required. And almost always, because these are very special patients, once they're unwell for medical team to be involved, the consultant is involved. If it's during daytime, we might go and review the patient, but they will always come to us and say that, okay, we have seen the patient she's in labor, but she had hemoglobin of 120 24 hours ago. She's in labor, but she's bleeding, and it's antepartum bleeding. And with that hemoglobin in blood gas is maybe 60. We get that as a quick estimation, but also we send the samples to the lab, and that's when everybody's involved, i.e. the hematology team together with the pathology team, the hematology lab. We just tell them that we are bringing the blood test for this patient. They will do lab hemoglobin within minutes to make sure that we get all the results together.
Okay, excellent, Dr. Mlawa. Yes, before I finish with Dr. Emma, I know she's going to give us her final discussion and feedback. Anybody in the audience who is going to, if you have any question, just prepare your question while Dr. Emma is finishing up, and then we're going to open for the floor. And if there's nothing else, then we'll be finishing our training. Okay, Dr. Emma.
Yes, thank you. I do want to say thank you to the other doctors for clarifying what they do. I think what I also do in my practice is very similar. Definitely you want to look at the clinical presentation, the patient's vital signs. So you could do like your own subjective estimate, but we also have weighing machines where we could weigh the used lab pads that the nurses will be actively collecting and giving you feedback of the weights and the estimated blood loss. And also the patients usually have a drape under their buttocks that will collect any bleeding that's coming out. And that drape is usually graduated, so you could sort of estimate how much blood is coming out. The only thing that you also have to estimate is, I guess, how much of it is amniotic fluid, because usually it's mixed together. So you will have to subtract, I guess, what you think is the amniotic fluid. But that's been very helpful because it's very objective. As everybody said, usually we tend to underestimate high blood loss. So it's wonderful to have that objective measurement that is usually more accurate. The other thing that we sometimes use when we do C-sections is called Triton, which is like it's like an imaging system that will actually image the canister of blood and amniotic fluid, and it will actually be able to separate, I guess, the amniotic fluid from the irrigation and actually just give you what is the real blood loss. So that's also very helpful. And what we have found is when we use that for C-sections, people used to overestimate the blood loss from the C-sections, but then with that system, it sounds like it usually gives us lower estimates of the blood loss. So that's also good technology that we have available at my practice. Yeah. But with all that, I do believe that the clinical exam is what trumps everything. You have the patient in front of you. You can see the patient. You can see the vital signs. You could see what's coming out of her. So I think you always have to go with that as the first and maybe most accurate way of managing the patient. Thank you.
Excellent point, Dr. Emma. That's definitely the I think one of the areas that everybody have to be good at it is just use the patient, the clinical presentation of patient, because that's what is going to guide you. Yes, the quantification is great. We can count and we can do anything else. We can do our math, perfect. But what is the patient response? Because some of them, yes, they might get to that 1,000, 1,200, which could be probably normal for majority of the patient, and they will still get up in the bed and after you take care of them and go to the bathroom without any issue. But some people, just 1,200 is too much for them. And then so their clinical presentation is going to guide you or support your diagnosis, and then of course put that anticipatory guidance quickly and address those issues with that patient. I know I have a few nurses in the group, and anyone you guys want to ask our esteemed expertise any questions? What have you seen as a nurse on the bedside that you want to share with the doctors? And then we finish the training. Anybody? Going once? Going twice? I want to thank everybody who has been here. Dr. Mlawa, Dr. Mugalu, Dr. Nestor, Dr. Emma, Dr. Daniel, Dr. Christine, all the people who came to the training here. Thank you very much for sharing your practice so we can all learn from each other. And as this discussion help us as a Qhsc to prepare for our medical mission or to add it to our medical mission, because we have so many things prepared for everybody over there in Tanzania. One of the biggest part is prevention of postpartum hemorrhage, definitely. And we already discussed earlier about all the treatment stuff, and now we're discussing about the screening of these moms. So bring the full picture of when you had a pregnant patient show up in your hospital, what exactly do you need to do? But at least now we have a point of reference. UK, they're doing this. Sweden, they're doing this. China, they're doing this. CCBRT, they're doing this. You know, like Mwananyamala, they're doing this. So at least in US, they're doing this. So it gives us more diverse response of these moms, and then so we can discuss with our nurses and doctors in Tanzania, and then be able to share what exactly other countries are doing and improve patient care. So our all goals is to save that mom's life and the baby. So if we can do that safely, and definitely that would be a better place for these moms, because as we know, statistically, people who are experiencing severe maternal postpartum hemorrhage, they end up dying, 47%. That is a number that we need to play around with it and bring it down as much as we can. So having this discussion, we thank you for your expertise. We thank you for your time. I know it's weekend, but I appreciate that part. If anybody has anything to say, so we ask everybody to show up in the screen, put on your cameras on, please, and then so we can have a good pictures of everybody who showed up this morning. Makeup or no makeup, that's okay. I'm missing some people. I have only 5 people. Come on, guys. Come and say so we can say hi to everybody. There you go. Thank you very much. Yes, thank you, Emma. Thank you, Dr. Mugaro. I appreciate that. Okay. Tanisha, she's hiding as usual. But thank you, everybody, and have a blessed day. So for people in Tanzania, we'll see you in 5 days and 10 hours. And everybody else, next time we do the meeting in Tanzania, so we'll let you know. So thank you, guys. Bye. Take care.
Tutaonana baadaye.
Yes,
Bye.
tutaonana baadaye. Bye, Dr. Mgalu.
Bye.
Bye bye.
Bye, thanks, Dr. Nestor. Yeah.
Thank you.
Okay.